Hello and welcome to episode 2, season 6 of Diabetes God. So today we're going to talk to someone super special to me. This is actually my consultant doctor at Queen Charlotte's Hospital, Imperial College, who assisted me, aided me, metaphorically held my hand at every appointment that I had with all the checkups that I had. And he's an incredible human. His name is Dr. Chucks. That's not his real name, but we'll get to that in the episode. Enjoy. So what is your role within clinic? Would you like to elaborate on that?
Part of my job is to, obviously, I support running the antenatal clinic, where we look after women with all types of diabetes during pregnancy. So that's type 1, type 2, and even, gestational diabetes. But kind of outside of the pregnancy side, I do just run general diabetes clinics. So that's type 1, type 2, diabetes with different complications, such as kidney problems. People develop diabetes due to things like pancreatitis, surgery. So, my job is very diabetes heavy. And specifically, the role in clinic is actually a really interesting question because we have to go into it for a long time. But what I'll do, actually, I'll push that back to you. What do you think our role in clinic is? Because that will be really interesting.
For me, genuinely, amongst all the blurb about, setting your pump to this and making sure you do this and do that, for me, it was having somebody literally hold your hand through pregnancy and to take the load off, like the mental load off the numbers, the figures, how much insulin am I having? And that for me was, I don't know if I don't know if many other patients have said that, but for me, it was just like someone's my tag team, someone's my partner in this that may not have diabetes, but you get, like, you understand it to the core more than my husband, like you get it. That's how I felt.
No, that's really interesting because, so I've been doing diabetes, from a kind of doing your diabetes registrar now for about 12 years. And I've been a consultant for about 5. And I remember starting off always thinking, well, you see, lots of people in clinic and, their sugar control can range from being great to, terrible or somewhere in between. And you kind of think, I've got 10 minutes and I'm going to just rattle out all this information and I'm going to fix everything. And I'm going to, once they've seen me, all their problems will be fixed. Yeah. But in actual fact, this is a lifelong condition. And these people have been coming to clinic for 20, 30, sometimes 50 plus years. And I think only when you start seeing the same people over and over that you realize actually this is real life, and there will be times when things won't be great. There will be times when life just gets the better of you, whether it be, job issues, it could be, people going through relationship problems, financial, whatever it is, the real world stuff that we all deal with. And just with the nature of diabetes being so intrinsically linked to your day-to-day life, it's only natural that you will see the ebbs and flows with your diabetes, with normal life. And it's not a case of seeing someone for 10 minutes and just seeing a number and, reading the right act or thinking, I'm going to fix this. No, it's not that. It's about just supporting along the way.
Yeah.
I think what's most important is, for me anyway, is that the person across the desk table understands. Like, they're engaged. And a lot of the time they'll get it. I'm going through this. Things are a bit tough. I know this is what I'm meant to do. If I know that then I've done my part. If I can educate you and get you on board and get you informed and make sure that you're aware and you understand all the complications and understand what to do and understand why, and I've armed you with all the tools, then I feel like I've kind of done my job, because I can't be there for every meal. I can't be there for every exercise. I can't be there for everything. But what I can do is give you as much information as possible, be supportive as much as I can, make you feel like it's not the end of the world when things are terrible, and appreciate that, there will be ups and downs, but as long as we're kind of heading in the right direction, then I feel like I've done my job. So a bit of probably doesn't answer your question, but
no,
that's kind of how I see it.
I say this a lot. I say this to especially young women who are thinking about becoming having a relationship, let alone starting a family. There's a lot of fear and a lot of stigma and a lot of nonsense out there. And I always say, even if you weren't diabetic, being pregnant is tough. It is hard work. It's a slog, especially in like the warmer months. It is awful. However, having something like type 1 diabetes on top of it, or even gestational, for example, if you've never experienced it before, is even tougher. And I think what you said there about seeing the bigger picture, those 10 minutes in our appointments was sort of like a relief. I just felt like I just go, whew, this is really hard. I'm struggling with this. And you kind of feel like, yeah, but this is also really great. Like, this is also really good. And it's just that balance, which I feel a lot of doctors, in my experience from my amazing diabetes nurse that's been on before, Lakshmi at Central Middlesex, who's a dreamboat. She has also said the same thing when we were looking at technologies before I even conceived. And she talked about the Omnipod, for example, and obviously with yourself when we met in January. Then in February, I got on the Ipso pump. So would you like to elaborate on the technology for those who may not be aware of what is out there?
No, that's really, I think that's really pertinent when it comes to type 1 diabetes. So, I mean, the landscape in diabetes, especially type 1, has changed quite considerably in the last, probably like 10 years, or more so in the last kind of 4 or 5 years. I'm not sure how long you've had diabetes, for quite some time,
years,
isn't it?
Yeah, a lot.
There you go. So you understand what it used to be and where we are now. And, we've kind of started with, you had type 1 diabetes. It was 4 injections a day, of easily, multiple finger pricks as well to monitor sugars. When you go low, it's just a case of hoping you can kind of sense the symptoms and have your material ready to check and then have that. And that wasn't that long ago. So now we'll move to a place now where, technology has evolved, and it started, the technology that kind of became more mainstream initially was our sensors. So, we have our continuous glucose monitoring, which is essentially, the little patch you see people wearing on the back of their arms. Probably people, walking across the high street with your dots. And what that's really doing is that instead of subjecting you to finger prick every time you need to get a blood sugar reading, that sugar reading will be continuously being checked by the sensor and sent to your phone. So you can pretty much just access your phone to see what your blood sugar is doing. And I think that was a big game changer, because not only did it lessen the burden of having to prick, which was really cheap, but it also gave the functionality of alarms. So a lot of people really struggle. So one of the biggest barriers for people maintaining good control is hypos, okay? You probably can attest to this. Hypo is terrible, and once you've had a few really nasty ones, particularly in compromising places such as work, in a meeting, conference, it can be quite, people find it quite embarrassing, because you're pretty much incapacitated.
Yep.
You can feel quite, doolally. You've got all these people around you, your what was a personal, private condition is now public knowledge. So once you've had a bad hypo, people often feel, I'm going to run high. I'm at work, I don't want to feel embarrassed, I'm going to run high. And that will invariably down the line cause, the issues linked with, having poor control. So the sensors help that you have alarms, you have alerts, you can track. It really, really, really changed the game. So that was kind of, widespread in type 1. And now, the kind of guidance is a little bit more relaxed. So there's certain cases in type 2 where you can get it, but the pumps really change it for the type 1s, because as opposed to delivering that insulin dose manually by pen, which meant whenever you're at work or you're in a restaurant, having to bring out the pen, dial it, blah, blah, blah. If you just had a pump on board, you can do all the delivery through that. So one, it's discreet. And then what really revolutionized things was the hybrid closed loop aspect of that. Yeah. I don't want to get into too much detail because it almost feels like I'm giving a lecture.
No.
But
it is, the hybrid closed loop is at the top of the game. And we've talked about it in the past. Access is really tricky for a lot of people. and, funding, et cetera, et cetera. There's so much red tape. But I also just want to say, and I'm sure you'll say this, if you are planning pregnancy or if you are pregnant, you're sort of top of the list. Am I right?
Yeah. So, I mean, type 1 diabetics now, the place has moved now where pumps are kind of pretty much accessible to most people with type 1.
Mm.
But then within that, there are people who have priority, as pregnancy, the time limited scenario. We need to get on top of the control as soon as possible, especially that early trimester where a lot of fetal development's happening. So not just during pregnancy, sometimes even if you're planning pregnancy, your center might decide actually, if your intention is to conceive within the next couple of months, if you're not on a pump, maybe we should kind of fast track.
Yeah.
And if you are on a pump, maybe we should think about the type of pump you're on, which will best serve you to achieving those, as I'm sure you're aware, very tight control targets in pregnancy.
I do. I think the tight control was just like, what? Are you serious? And also it was the amount of insulin that I was having, especially in the third trimester. So once again, I switched from the Omnipod to the Yopsipump. So that's kind of what I'm still on, like postpartum as well. Obviously, I'm having conversations about, do I go back or do I keep this? For me, and I think you said this in one of the clinics, and it stuck with me. And now it makes sense because my baby boy, Dylan, he's 9 months and he's grabby. Everything's going in the mouth. And the wire, because I have it on my arm, the wire, there's been moments when he has tried, without realizing, to sort of yank it. And the worst case scenario, it just comes off and it's a bit sore. But that I can see could be an issue going forward. So I'm thinking about, shall I go back or shall I stick or shall I pop it somewhere else? But it was good that you planted that seed in my head because I didn't think that far ahead. And also another thing was, I don't know if other women choose to wear their devices during labor. I did. I ended up having a C-section, but I had it with me because it's a part of me. So that also really helped as well. During like the actual birth process, are hospitals, depending obviously where you have your child, are hospitals aware of these systems, as in the hybrid closed loop, or is there a little bit of uncertainty across the board?
I think that's a good question. I think, to be fair, if you have type 1 diabetes, that will automatically kind of put you in the category of a higher risk pregnancy.
Yeah.
So I'd like to assume that if you've got type 1 diabetes, it's probably going to be managed in a center that looks after more complex cases.
Okay.
And they should have the capacity to know what to do. I mean, to be honest, even where we are, because there's so many different pumps, so many different systems for type 1, I'm not surprised if people in obstetrics saw the pump and didn't know what the hell it was.
Yeah.
And a lot of the times they don't. And why should they, right?
Of course.
How many different pumps in the market? But that's where that collaborative work with the local diabetes team comes into place. And if you're type 1 diabetic and you're pregnant and you're being managed in an antenatal clinic, you usually see someone like myself in that clinic. You will have a buddy. It's almost like a buddy approach. You have your obstetrician to deal with the kind of pregnancy stuff, but then you have your endocrinology and diabetes consultant to kind of make sure the diabetes side is ticking along. And that will continue to do it.
Yeah, and I think that's what is the most important thing. And obviously, once you've had your child, you may go back to your regular clinic. So I went back to Central Middlesex, obviously. But there is that sense of, just like I said earlier, like there's you're one person, and like you said, your buddy that is holding your hand literally throughout everything. Absolutely. And sort of holding a mirror up in a positive way. Like, are you aware of this? What do you think of this? And because you can't think that fast because you're growing so big as well, and the baby's growing so fast that you're not thinking far ahead. For example, you mentioned during labour, so obviously it was an induction that didn't go according to plan, and then it became a C-section. However, you mentioned snacks. So if you have a hypo, what are you going to take in your baby bag for yourself? And if you are going to have a C-section, then you may not be able to eat full meals. So long release sort of, carbs and things like that. I mean, these are all the nuggets of information that I would never have considered. Has this come from experience, or is this something that you've sort of learnt along the way?
I think it's a thing we kind of pick up along the way, and sometimes you read stuff, you hear stuff anecdotally from colleagues. Sometimes you even hear stuff from patients who've said, "Yeah, my last pregnancy I did this," and you think, "Well, yeah, kind of makes sense." And you just kind of gather as much information as possible and add it to your arsenal. The crap stuff you kind of leave. You take the
Yeah, of
good stuff.
course.
And you kind of build up your own thing, really. Yeah.
Yeah, and I also think, like, since you've joined this wonderful world of medicine, I had a thought. I was like, what made you specialize in the care for diabetics? What was the reason when you joined medical school? Why did you decide to go down this path? Because you're really passionate about it.
Well, I'm glad that comes across.
It does, really does.
Well, actually, so where I trained at Imperial, I mean, they teach endocrine diabetes really well. I think a lot of the faculty are diabetes and endocrinology specialists. So I think already, because it's well taught, you kind of have a gravitation for it. You kind of feel like it's an enjoyable topic to kind of get into. And it's one of those things, once you start doing that, you start, pursuing endeavors in that field. So whether that be research, whether that be articles, whether that be going to conferences, and then your kind of CV got, leads you down the garden path.
Mm.
And then, once I applied for specialty training, that was pretty much it. And then, I was given a great opportunity to do research in diabetes. And then once I spent, 3-4 years doing research in just diabetes, it pretty much sealed it for me.
Yeah, I always wondered this. I've always thought, why do certain nurses and doctors and specialists go into the field that they've chosen to? Many have said because they've got connections with their family members or siblings or something like that, and they just want to help. Such as I know I've just forgotten her name now, Dr. Colosis at Central Middlesex. Her mum was type 1 diabetic.
Yeah.
She's an absolute, she knows, as you mentioned before about knowing the person, she's known me for a number of years, and she's known about my life's ups and downs and this and that. And what is the end game? How can I help you to get to where you want to be? And that approach in medicine to the patient is the most humbling thing, because for many years, I know I was anxious to go to the hospital because I thought they're going to pull me up on my numbers. They're not great. I don't know what to do, and I don't want to ask. And then when I got referred to this particular hospital, I just thought, I'm just going to ask them. I'm just not sure about this. I don't understand what that means. And having that sort of a flow of a conversation doesn't feel like an appointment. It feels like I said, that it's a part of a tag team. And, the clinic at Queen Charlotte's where I met you, it was busy. It was absolutely rammed. Have you noticed the number of women with type 1 diabetes, specifically, who are trying to get pregnant, who are pregnant, has gone up? And what do you think the reason is behind that?
I think type 1 is pretty much set, right? I think that hasn't really changed too much. Now, the number of women planning to get pregnant, I think we're probably picking up more type 1. So the numbers I don't have the exact figures. The numbers might be slightly decreased in that sense. But also, women are having children a lot later as well.
Mm.
So, you get the young women who are still having kids, but then you also get later pregnancies, which then are slightly more complex. So if you have a type 1 who is in their 40s, getting pregnant, and that also has the risks of age and the type 1 combined. So that makes the pregnancy in itself more challenging. But the nature of the clinic is, it's a lot of the type 2s and the gestationals, and that's just sometimes, we know that, obesity numbers are higher, type 2 numbers are higher, but also the population we serve in West London, ethnicity as well, that's a big risk factor. So you get a lot of, Black African Caribbean, Asian, Arabic, and this is where the prevalence of diabetes is a lot higher. So that clinic just, it's the melting pot where all the high risk cases kind of converge. Yeah.
I definitely thought that. I definitely thought when we were sat there, was someone else that I met through one of my antenatal classes was there. And I was like, what are you doing here? You're not diabetic. She's like, no, I've got gestational. I was like, oh, okay. So there was quite a few like other people there that I kept seeing. But I sort of felt like I knew all the staff. I felt like I knew the lady that was doing my bloods. And that was the atmosphere that was really calming. And especially if you've had diabetes for a long time and you think, I've got a handle of this, and then you fall pregnant and then everything you know just goes out the window. Like it's not the same anymore. With the technology, as we mentioned earlier, it has got to a point, I don't know, I might be wrong. We've stopped at hybrid closed loop. Do you think something more advanced is going to come, or where do you see the technology sort of swaying towards? Because wearing all these devices is great, but as I mentioned, there can be risks of being yanked off. So what do you think the next stage of technology could or may be?
It's a really interesting question. I remember with my PhD supervisor writing something around this a few years ago. Because I think it's twofold, right? So I think the technology can improve, but the technology is also going to be hampered by the pharmacology of insulin itself. So the fact that if we're delivering insulin subcutaneously, that by default has its barriers. Subcutaneous insulin takes, sometimes 15, 20 minutes to become active. So there's a delay there already. So whatever we're doing, you're always kind of playing catch up in some regard. When your body makes insulin, it squirts it directly into your bloodstream. So if your glucose just makes the slightest fluctuation, your body's onto it straight away. Here we're kind of using a sensor which already has a bit of a lag, and then the sensor then has to tell the pump to give the insulin, which also has a bit of a lag. So we're kind of behind the curve somewhat in terms of controlling things kind of reactively. Now, when you add a meal on top of that, I mean, your sensor can't predict when you're going to eat, right? So you have a big carb load, your glucose takes off. By the time your sensor then sees this and tells your pump and your pump reacts, you're probably 20, 30 minutes into a sugar of 15, 20, hence why you have to bolus pre-meal. So it's never going to, as it stands, that's probably the biggest barrier to having a completely closed loop system where it's hands off. You slap on a sensor, slap on a pump, eat whatever you want, and your sugar just gets controlled. The insulin can't react quick enough to your glucose responses after meals. But I mean, technology will get smaller, which I think will help. I think the sensors will get smaller. Sensors should get more accurate. I think the pumps might also get smaller, cleverer. You might get devices where the pump and the sensor are all in one.
That would be pretty good, yeah.
I could imagine something like that coming along, where you're not wearing two devices; it's all housed in one unit. I think there's still room for things to improve. AI as well, and all the machine learning and predicting glucose levels and reacting. So yeah, technology is always moving, so I'm sure things will improve, but it's just the nature of insulin makes it a bit tricky.
Yeah, of course, that's the thing, and the nature of it and the way it reacts to the body and sort of playing catch up as well. And everybody's bodies are different as well. If I eat something and then my diabetic best friend eats something, the way our sugars go are slightly different as well. So there's a lot within those two as well. And I remember I just remembered what you said about things getting smaller. I remember the days when it was the Libra 1, the flash monitors. So I remember when it was first given to me. So I've seen the iterations throughout, and obviously now I'm on Dexcom. So all these iterations are happening across the board. And from a design point of view, I'm very fascinated by it. But I do agree that if there is something where the pump and the sensor could be smaller or combined and waterproof, that's another great one. That's what I miss about the Omnipod not being waterproof. That would just be like easier in a full convenience, obviously. But currently, with what we have, you know, with myself, I do wear it. So I wear something over it. I don't really like to have it on show too much. I've just always been like that. Unless I'm on holiday, it's a different story. But I think that's another barrier for a lot of people, let alone women, showing their devices as well and having them on and people questioning them. So do you find like when you have tried to get people onto devices, they've been a bit resistant because of that, of visibility?
Oh, yeah, absolutely. Absolutely. Some people, it's a journey, right? Some people don't want everyone to know. Some people think it has negative connotations or whatever connotations they feel, they just associate that with, having a medical device attached, whether they're not paid more, whether they're, everyone's different. And for whatever reason, they have these beliefs. And it's trying to kind of work within those. I don't want to say we should change them, but we should just try and maybe challenge them. Because ultimately, look, some people actually, a pump isn't for them. Let's say you're someone who works in an environment where things are going to get caught all the time and it's going to be very risky or, and actually your control is perfect for pens and you've got it nailed to a T and you're happy using pens. The aim of the game is good control. And if you can achieve that for pens and you prefer using pens, then actually why should I force a pump on you? I think it's for those who where the control is, they're really struggling and they've exhausted all their means with pens, but then they don't want to adopt a pump for reasons such as, having it on display. It's there where you have to try allow them to reach that point. And maybe it's a psychological thing and, we do have specialist psychologists who can, speak with them about, their hang-ups about their disease, but it is the relationship they have with their diabetes.
100%, 100%. And I was offered a dummy pump before I had the real pump, and it was just like a stick on, and just to see what it was like for 24 hours. And I think that really helped me take that step onto thinking this is for me. Speaking about this is for me, we're approaching the end, but what advice, now this is my favorite part. What advice would you give, I would say, to couples, not necessarily even women? What advice would you give to couples who are thinking about starting a family? And in this instance, the mum herself, or shall I say the female, has got type 1 diabetes. What advice would you give them as a couple?
So I'll start by being positive to say it's possible.
Yeah.
Lots of women do it. There's lots of success stories. Having type 1 doesn't mean you can't have a family. So by all means, be excited, feel motivated, and there's lots of support out there. I think what the couples can do is understand that it will be a bit of a journey, and you can start by making that journey easier by what you do pre-conception.
Of course.
If you can really get your control, get it as good as you can. I know sometimes, some of the guidelines, they get it to below 48 HbA1c, which for some people is just difficult. And if you ask them to do that, they'll never fall pregnant. So in your late 30s and, you think, I've only got a certain window to try and get pregnant. We have to be reasonable, right? But if you can do what you can to get your control a lot better, so as tight as you can, it will definitely help that transition. Because a lot of the complications we want to avoid, so the fetal developmental issues, miscarriage, etc., that's in early pregnancy. If we can go into the pregnancy with good control, then we're not in a place where you're falling pregnant and now we're having to, change the foundations, get new furniture, put in new windows, we're having to fix everything in a short